Okay, sorry about the delay. I somehow had an IT person in here and they locked me out of Zoom and I could neither unmute nor put my video on. It was very interesting. All right, I think looks like lots of people have joined, so we will go ahead and get started. If you will start us off, please, Sonia.
Great, well, thank you. So we'll go through our accreditation statement and EOE statement here on the screen. Let's see, Dr. Raval doesn't have any disclosures for us. And if you are needing CME credits, EU credit, you can either scan the QR code here on the screen, or you can click on the link in the chat box. On the first screen, you'll be asked for your Blazer ID. If you don't have a Blazer ID, you can go on to the second screen and then put in your personal information. Just so you know, our CME application is under review. So even though it might not show up on your transcript, we do have a record. And as soon as that's unlocked and I can get in and add attendance, then I will be able to do that. So note, please don't panic. We do have a record of everyone's CMEs.
Awesome, thank you so much. So I'm going to go ahead and start us off with the case before turning it over to Dr. Raval for our didactic. This case has lots of angles that we could talk about, but so this, yeah, see what you think. My disclosures. All right, how did that get there? Hold on. How to move this. Okay, so this is the patient we're going to be talking about. She's a 26-year-old Black female with hemoglobin SC disease. And her biggest complication without question is her morbid obesity as well as her depression. So I met her in 2019 when she underwent a sleeve gastrectomy for weight loss. It seems to me that her problems almost started then. She had intermittent issues before then, but it seems things got worse. She did well overall, lost at least some weight until we hit her COVID infection in 2020, where she was admitted, initially thought to be concerning and hypoxic, but mostly, remember, this was early in 2020, and given her multiple comorbidities, we really just admitted her to watch her. She actually didn't need anything, but really had a lot more acute and chronic pain after that admission. Other past medical history, she has obstructive sleep apnea, again, very frequent pain, depression, mild asthma, mild retinopathy, I think it's a grade 2, stage 2, and a history of DVT, but it's actually a catheter-associated VTE from her port. She's on Eliquis for that. She lives with her mother. She was working and attending school, but is now doing nothing, essentially. She has very few friends and confidants. She really has some anxiety, significant depression. She's been on and off Zoloft. She does find it helpful. She sees psychiatry, she sees a therapist, and she had a passive history for a little while of suicidal ideation, but no true suicidal ideations, and no homicidal ideations, no hallucinations, nothing along those lines. Leading up to where we are right now. So as I mentioned, in 2019, she had a sleeve gastrectomy, and her weight natered after that around 280 pounds. But really didn't last long. And by mid-2020, she was up to 330 pounds again. She had said she'd lost 70 pounds. I think she'd lost about 40. I think her starting weight was around 320. It's hard to tell. The COVID that I mentioned that she had, but it really seemed to make things worse for her. Not long after COVID, she really had a lot more chronic pain. We started on gabapentin. A fentanyl patch was added for chronic pain, as it seemed like perhaps she was having some intermittent withdrawal when she'd take her short acting for several days and then stop it. But really her increase in acute care was notable. She went from really not ever coming into the infusion therapy unit to coming in all the time. She had started and restarted hydroxyurea on numerous occasions, in that she says she doesn't like the way it makes her feel. It makes her feel yuck. It makes her nauseous. She's on a low dose of it now. In early 2021, she did start on Adakveo, and she did find that helpful. She also started with psychiatry. Her Zoloft was restarted. Her follow-up remained fairly inconsistent though. And really, for the next year, nothing really changed. We were on Adakveo. She was on a low dose of hydroxyurea. She was on a good dose of Zoloft. She was sometimes seeing psychiatry. And then in May, she started with our pain psychologist here, should say psychology, not psychiatry. We also stopped full agonists and started her on Suboxone because despite every opioid we'd given her, she really didn't improve no matter what we did. Now, while this seems like a story about pain, it really actually isn't, though we're going to get back to that. So in July of 2022, she was admitted for cholecystectomy and received 2 units of blood prophylactically for that surgery and recovery. And then she was admitted again in August for COVID. This was, as I mentioned, her second round of COVID. She really didn't need to have been admitted. Complained of symptomatic shortness of breath, was really never hypoxic. Did get a unit of blood during that admission to see if it would help her symptomatic hypoxia. And then she came back in September, just a couple days ago. She's still in the hospital, current patient, for what she called vaso-occlusive pain, but was nothing different or abnormal from her usual pain. She was afebrile. Her vital signs were completely consistent with baseline, no hypoxia, no nothing. But her labs were noticeably different. Her T-Billy was slightly elevated for her. She really has almost no evidence of hemolysis at baseline. So it was around 2 to 2.5, but her baseline hemoglobin was 7.2, which was down from 8.9 a week before that. Her LDH was about 200, so nothing too exciting. And we'd planned to transfuse her, and I didn't have a great reason for that. She had a decent reticulocyte count response. I don't have it, but it was relatively appropriate. And when we got her type-in screen back, she had a new warm autoantibody, a positive poly-DAT with a weak IgG, and her complement was negative. So what did we do? Well, it was hard to tell. Was this sort of a delayed hemolytic transfusion reaction? She did have this blood, 1 unit of blood during COVID. We were just at the border when you'd think you'd see a DHTR. She really wasn't having abrupt hemolysis. As I mentioned, her LDH was 200, 300, nothing like the normal 1700 you'd see from somebody having a DHTR, but notably lower than her baseline hemoglobin of about 9 to 10. And so we gave her IVIG and a gram per deciliter over 2 separate days, and her hemoglobin continued to drop, nadir at about 4.7. She, of course, was only having pain. She didn't have any other symptomatology, was mostly mad at us that we wouldn't switch her from Suboxone to IV Dilaudid, which we eventually did. And then we actually had our heme team take over, and I had started her on dexamethasone, and they gave her prednisone. And we asked them not to transfuse because we really weren't sure if this was truly a warm auto versus a DHTR. But she got a couple units of blood because they didn't notice that we requested not to transfuse. So she got 3 or 4 units of blood. We'd also started her on Procrit and given her IV iron. And her LDH actually increased after transfusions, but still never got very high, up to 447. Her T-Billy never went above 3. Again, nothing that exciting. We've seen a gradual improvement in our hemoglobin up to 8.6 and a retic count of 12.5%, which has been pretty robust, making nucleated red cells. And after 3 units of packed red blood cells, I had them out of curiosity because it seemed like she was just hemolyzing the blood she shouldn't have gotten. And sure enough, her hemoglobin A was only 11%. Obviously, we would have expected it to be higher 3 days after a transfusion. So this is where we are now. We've gotten her back on her Suboxone. Her hemoglobin is 8.6 with a retic of 12.5. She has some very mild hemolysis, again, a bilirubin of about 2, and LDH that has gone back down into the 300s, and that's where we are. So questions for the audience. What would you do? How would you treat her? Would you consider this a DHTR versus a warm auto? And another question that I had is whether anybody else has been noticing more both allo and auto antibodies post-COVID. We seem to have a lot more of them, and I wondered if any other sites have noted the same thing. Really, I need your help. You got to give me some thoughts here.
Dr. Cantor, the steroids, did that cause a bump in her hemoglobin level?
It's a great question. I don't have an exact answer because the same time, so we gave her IVIG she continued to nadir all the way down to 4.7. And then she was given all this blood that I don't think she held on to, but I can't tell you 100%, and given steroids all at the same time.
Interesting.
And do we know
Very
for
interesting.
sure it's not an allo?
We
Is
know for sure it's not an allo, yes.
that- Well,
She
it
does have an allo antibody that has been previously identified. We did not find any new allo antibodies.
Mhm. The good thing you don't have to transfuse it right now.
Right. I mean, we definitely don't need a transfuser right now. I think that's certainly true, but I'm also not really sure what it was, and I'm curious to hear what other people would have done. Today, her steroids were actually stopped. And I think we're going to watch her for another day or so. But I'm at a bit of a loss. I mean, and we see this, we see her a lot. She comes to clinic at least weekly, sometimes twice a week. And so we didn't see this drop in hemoglobin before this time. I mean, it was notably different from the last time she'd been seen before coming in was August 25th, and then this was September 4th.
Dr. Cantor, the DAT test, was that done after transfusion or before?
Before, that was done on admission before we transfused her.
Okay.
I mean, it sounds to me that most likely was a delayed hemolytic reaction, no? Because it happened after, although you kind of prevented that because you gave the steroids and so it was not a very brisk one because you gave steroids, you gave IVIG, and then she got better.
I mean, I guess, I'm not sure that really we did anything, to be perfectly honest. She got worse before she got better. I don't really know what made her better because we did too many things at the same time.
Mm-hmm.
Dr. Cantor, was there any change in the platelet count over this?
No, they were pretty much fine. I was actually checking her platelets today, and they've been, at least for the last 5 days, consistently between 150 and 200. Rarely do you actually see somebody with that consistent platelet count.
True.
It was just, I mean, even for either a DHTR or a warm auto, I would have expected a lot more hemolysis, as
Right.
evidenced by a higher bilirubin and a higher LDH.
Right.
Yeah, I was going to say, I think you will see Coombs positivity with a DHTR and warm auto because it's basically the presence of antibodies on your own cell. So I think that is, so it makes it harder for us to distinguish between the two. I've seen some warm autos that don't have a lot of hemolysis, and they primarily present with spherocytes on the peripheral smear. And I don't think I have to go back and look at her chart and see if they've noted any spherocytes on her differential or not. But I guess in terms of treatment, the treatment managements are kind of the same. I don't know if it's helping her, but since we're thinking about warm auto, we definitely give most of our patients, I think first line is rituximab. So that probably would do her some good to have that just if we're thinking about it. But like you said, I think she got better. It was a very interesting case. Yeah.
That's quite interesting.
It doesn't seem the transfusion, with 3 units of blood, you'd think you'd have a lot more robust hemoglobin A, and her LDH went up post-transfusion, which made me think this was more likely that she hemolyzed the blood she got, which was least incompatible and shouldn't have been given to her. So my next question is, how would you all treat her? She has terrible chronic pain. Nothing really makes her better. Really significant depression. She does most of what we ask her to do. I mean, she's in an intensive outpatient psychiatry. She goes to her sessions, but I don't feel like we've made any headway in anything we've done. And I figured I was really wanted to present her because I thought her hematology was so interesting this round, but would love thoughts on the psychosocial approach to managing her. We've switched her to Suboxone because while she'll tell us she's not better, she's also not worse. She's almost identically, stably not good.
Could you just clarify when her gastric bypass was, and are they monitoring the B12 levels for her? Because B12 sometimes can cause these weird neurological effects. And if you replace that, it sometimes resolves.
That's a great question. It was a gastric sleeve sleeve gastrectomy. It was back in 2019 and I'll have to double check. I know we've looked at least once at our B12, but I don't know that we looked at this admission. That's certainly worth looking at. Any other thoughts? Has anybody else seen more antibodies in patients who've had COVID? I feel like we just see more alloimmunization this year than I've ever seen.
Dr. Kander, was there any association with any new medication? I mean, I know that she was on and off on Hydrea at times and such, but what would that coincide with when we checked her Coombs?
No,
Whether she had just restarted one or not.
no, she's been on, if you consider what she takes on, which I think is highly questionable, on a low dose for months, no changes. Meaning whether or not she actually puts it in her mouth is not clear.
I see. Fascinating.
If anybody can think of anything else, we're all ears. I mean, really, she's, we feel like from a psychiatric and psychologic standpoint, we've done everything and she's done it. She's continued to work with our pain psychologist and Dr. Morais, I don't know if you have any other comments.
No, I mean, it's been a very challenging case given the severity of her pain and whatnot, but I would say that the noted improvement I've seen is that she has become more aware about how, her low self-esteem, her negative perspective on life, her doubts, how they affect her. So right now we're working on kind of implementing strategies to change those views. But, she focuses on negative things, dismisses the positives, has very unrealistic expectations about herself and others. So we're doing some of that cognitive work.
And I was just wonder, I think, like you said, Dr. Mariah said, she's very kind of challenging, but another thing I always wonder is just in cases like this where there's a lot of, depression and other underlying psychosocial things, how long does it really take for us to see an improvement? I don't know if the amount of time that she's been on Suboxone, the amount of time she's been on this intensive treatment, even though it's intensive, you expect it to happen in a month or 2 months, but perhaps it's just something that's going to take a long time and that we're just consistent and knowing. For us, I think it's hard because we're like, is there anything else that we can do, or is what we're doing, right? But I just wonder if it's just time that over time that we might see some improvement.
No, I think that's a good question as well. I mean, obviously, I think we're not going to be transfusing her, putting her on chronic transfusions anytime soon. And so I assume, we'll continue her Dacvio and discuss whether or not she's actually taking hydroxyurea. I did wonder if anybody else had any other thoughts. I do think she's slightly better on Suboxone, that she would not say that. Her affect seems better.
I have a question for you, Julie. Do you think she would be, I know SC disease right now, very few of them are getting transplanted or gene therapy. Well, I guess with the transfusion issue, probably not, but even for transfusions, we're not prohibited given her course, still not.
I don't think so. We see enough chronic pain post-transplant and post-gene therapy as well. I have several of those individuals now. For those who don't know, we have several individuals post-transplant or post-gene therapy maintained on Suboxone now. The most interesting was a referral to me from another physician. He just moved to Alabama and he was miserable. He actually had a lower quality of life now. He's 100% engrafted after a haplo. And he just started Suboxone and feels so much better. So I think we really have to look at the post-transplant pain. Perhaps it's not all chronic pain from sickle cell disease, but rather some chronic hyperalgesia. Because the patients that we really had trouble with post-transplant, now that they're on Suboxone, are so much better. But in her, I think we have to fix a lot more things before I'd feel like she was safe to transplant. Any other thoughts?
This is Turin. I'm one of the fellows at St. Jude. To Dr. D'Souza's point, it sounds like a lot of the issues happen post-gastrectomy. So I don't know much about what happens to medication absorption post-gastrectomy, but if she was stable, quote unquote, pre-gastrectomy, and then I think she's still on the Zoloft, could that have affected the absorption? Did she go through some Zoloft withdrawal if she wasn't absorbing it as well? And could that have triggered some issues? I don't know if it's worthwhile having a conversation with pharmacy about that kind of stuff, just because it could be very complicated.
No, I think that's a great question too. You know, I think of her as worse post gastrectomy, but I also, our program's a lot different because that was all in 2019 when we arrived and changed the whole program. So some of it may be that she was having a lot of this, but was less visible because we didn't have 5-day-a-week clinic and we didn't have the availability that we do now. But I think it's definitely worth looking into. Again, I don't know. I have no idea if there's any concern with Zoloft or other medicine absorption in that way. Any other thoughts? All right, well, if anybody else sees anything, you know, weird antibodies post-COVID, please let me know because I'm on the lookout. From there, I'm excited to turn it over. I'm going to stop sharing. Dr. Raval, are you going to share your slides?
Absolutely. Let me see if I can share the screen. Can you all see the screen?
Yes, we see your PowerPoint slides. You want to go into
Okay.
presentation mode.
Now, well, in this double monitor, I'm trying to figure out which screen to share and which. Wait a minute. Excuse me.
I think you might be in presentation mode now.
Yeah, are you
Yep.
able to see my screen?
Yes.
All right, great. So, so thank you for this opportunity. My didactic today is sickle cell disease and thrombosis. This is the area of my interest as well. And so I wanted to start with the pathophysiology of venous thromboembolism in sickle cell disease and kind of go back to basics as far as the Werkow's triad goes, the hypercoagulability, stasis, and then endothelial injury, and how each one of those components is affected by sickle cell disease. And so this was a good article by Dr. Shet and Dr. Maria in the Journal of Molecular Studies, where they say that in a sense that when we have a sickling process going on and the release of hemoglobin, it causes expression of tissue factor in endothelial cells, which can then cause the hypercoagulability part of the triad, hence contributing to thrombosis. Then also there is a concern that because of microthrombi, which if it affects the circulation of blood in those capillaries and contributes to stasis. And also there is release of endothelial or extracellular vesicles along with activation of the endothelial cells from heme-associated injuries, decreased nitric oxide, hence, you know, from the sickling process, and that will cause a decrease in scavenging of free radicals, which and decrease in vasodilation, again augmenting all of these three factors. And this was mainly a slide to kind of underscore that all of these three kind of legs of a tripod or triangle in thrombosis are exaggerated in patients with sickle cell disease, and hence contributing to an increased risk of thrombosis in patients with sickle cell disease. So that was the first. This was a great paper in Blood Advances in 2020 about increased risk of CVA and venous thrombosis in patients with sickle cell disease. They took about almost 1,100 or 1,200 patients with sickle cell disease, adults and kids. Median age was about 24 years. More than half were female and more than half had hydroxyurea use in the past. Now, I think we had a really good didactic earlier on about CVA in sickle cell disease, so I'll kind of keep my comments restricted to VTE part. And so to that end, multiple factors have been shown here to be significantly associated with development of VTE in patients with sickle cell disease, ranging from hydroxyurea use, the sickle cell beta 0 thalassemia, presence of the patient's white count being elevated, which were all associated with development of VTE in sickle cell disease. So the cumulative incidence of thrombosis was almost 17%. This was accounting for VTE and CVAs. The risk factors were, like we mentioned earlier, the older age, S beta 0 cell for the recurrent CVA part. And then there was a glomerular filtration rate being low, hydroxyurea use, elevated hemoglobin and leukocyte counts, and S beta 0 and SS were risk factors for VTE. As expected, DOACs are associated with a lower risk of VTE recurrence compared to other anticoagulants, and they were able to identify 2 thrombomodulin gene variants which had modest associations with thrombosis risk in this study. This are the most recent ASH guidelines for VTE treatment in sickle cell disease of 2019. The total of 3 studies evaluated the incidence and risk factor for VTE in adults with sickle cell disease, about 8,000 almost patients, and the incidence, including pulmonary embolism, which was expectedly higher in patients with sickle cell disease than DVT is, about 11.2% in all adults, and 17% in patients with severe sickle cell disease, defined as more than 3 hospitalizations per year. Female sex, more severe disease, and severe genotype are associated with VTE risk, along with a high incidence of 5-year recurrence. There was an association of overall increased mortality in patients with VTE amongst patients with sickle cell disease. And then there was an increased risk among pregnant women, especially in pregnant women who also had pneumonia, vaso-occlusive crisis, and acute chest syndrome, where all of those contributed to a higher incidence of VTE in sickle cell disease pregnant women compared to those who either were not pregnant or did not have severe manifestation like the pneumonia, vaso-occlusive crisis, and acute chest syndromes. So I have the original study later on elaborating on that. The incidence of VTE in children, I'm not a pediatrician, so please feel free to jump in on the rationale of some of these studies. But there were 2 studies that reported a total of 10,000 children. The incidence was ranged from 1.7 to 2.9%. And the risk factors are all the kind of usual suspects that we see in patients who develop VTE even as adults: presence of central venous catheter, length of hospitalization, ICU stay, older age. Female sex was a new one for as far as the comparing it to the adult side, where we see a higher prevalence of thrombosis in male as compared to females. And the history of stroke is self-explanatory, was independently associated with death in children with sickle cell disease. So kind of underlining the gravity of VTE in patients with sickle cell disease. That brings us to the safety of anticoagulation in VTE. Again, this is ASH guidelines. 3 retrospective studies found that there was about 116 patients, 5 of them developed hemorrhage with VTE prophylaxis. In a small retrospective cohort study, about 14% patients on DOAC developed non-major bleeding. There were no major bleeding involved. Now, this was a small study, 22%. But then when we look at a bigger cohort, about 5,800, 6,000 patients, you had a cumulative incidence of bleeding of almost 5% at 6 months and 8% at a year. So this was a very good study about the risk factors, recurrence, and mortality in patients with sickle cell disease and VTE incidence in these population by Dr. Brunson in British Journal of Hematology in 2017. Looked at about 6,237 patients. The thrombotic event was present in about 700 patients. And this is the breakdown of these thrombosis patients, where we had about half of them developing PE or VTE, and the remaining half upper extremity, 22%, upper extremity DVT, lower extremity DVT in about 2.5%. And then proximal lower extremity DVT in about 20%. This is the breakdown of the 11.2% rate of thrombotic event in patients of all gender who developed VTE in sickle cell disease. As we see here, there was a significant proportion of them. There was a higher proportion in females than in males. Again, this is something that was a retrospective study. I don't know the rationale for that. Usually it's the male sex that's associated with increased thrombosis. The severity of the sickle cell disease process is expected correlates with development of thrombosis as well. These were the risk factors of for VTE. As we see here, again, there was an increased risk of VTE in females and in patients who had more severe sickle cell disease. The race or ethnicity of the patient was not significantly associated with VTE development in sickle cell disease. The cumulative incidence by age 40 in sickle cell disease was 17% compared to 8% in matched asthma cohorts. So more than double risk of VTE in patients with sickle cell disease by age 40. This was trying to kind of underscore on how the severity of sickle cell disease correlates with VTE development. And as we see, the solid lines are severe. This is severe sickle cell disease. This is severe asthma. This is non-severe sickle cell disease. This is non-severe asthma. So in each cohort, the severity of the underlying sickle cell disease, predicted for a higher risk of VTE incidence as patients' age progressed. Incidence of recurrent VTE and not the primary event by sickle cell disease severity. And as we see that this more severe sickle cell disease patients had a higher risk of recurrence from VTE as compared to those patients who had a milder course. So this is the hazards ratio for survival among sickle cell disease with VTE. So VTE was associated with increased risk of death, almost the hazards ratio being 2.88, quite significant. And again, kind of, pointing that VTE is an independent risk factor for mortality in sickle cell patients. The 5-year recurrence was about 36% in patients with severe sickle cell disease. As we see here, recurrent thrombosis, again, female sex, severity of the disease, and the prior thrombotic event, whether it was a PE DVT or upper extremity DVT, were all associated with recurrence risk in patients with sickle cell disease. And that was a quite high 5-year recurrence rate of 1 in 3 and more would develop a recurrence in patients with severe sickle cell disease. This was a pediatric study where the prevalence and risk factor of VTE in children, almost 10,273 kids were analyzed. And again, as expected, stroke, chronic renal disease, obesity, presence of a central line, ICU stay were all significantly associated with risk of developing VTE in kids. VTE in pregnant women, baseline risk much higher, about 2.8% as compared to 2% in the general population. And so higher still if those women developed pneumonia, vaso-occlusive crisis, or acute chest syndrome during pregnancy. Very significant p-value, 6.6 versus 2% in the absence of those 3 conditions. Again, predicting for increased VTE risk in sickle cell disease patients who are pregnant. This is the VTE risk by sickle cell disease genotype. The SS or S beta 0 comparing would have the highest risk of cumulative VTE, followed by SS and alpha thal, followed by SC disease and S beta plus. Again, no surprise there, but it was good to kind of look at that in a graph where we see that those different genotypes predict for significantly different risks of thrombosis over time. This was the same thing in a table form where we're seeing that for all genotypes, we have a 5.2% risk. Again, the SS S beta 0 has the highest incidence per 1,000 person years, 7.6, followed by SS alpha thal, followed by SC/S beta plus thalassemia. The VTE incidence, 5.2 per 1,000 patient years, rate of 6.7 per 1,000 patient years between ages 15 to 30. The incidence was 4 times that of factor V Leiden carriers, which we would, put patients on indefinite anticoagulation for if they eventually develop blood clot just looking at the adult side of things. Overall survival by VTE status, again, kind of pointing to the same thing, that VTE is an independent risk factor for mortality in patients with sickle cell disease. VTE recurrence by sickle cell severity, as we see here, this is the line that the patient has DVT. This is PE with or without DVT, and this is upper extremity DVT. So just looking at it visually, we see that patients with severe sickle cell disease, defined as more than 3 hospitalizations in a year, have a much higher risk of VTE recurrence and cumulative incidence as compared to their less severe counterparts. This was, again, the risk factor for VTE recurrence and bleeding, both taken together. And again, more severe sickle cell disease, higher risk of recurrence and bleeding. Almost reminded me of how malignancy does the same kind of an impact on patients, that you are at a higher risk of VTE, but then when you anticoagulate them, you're also at a higher risk of bleeding. So 1 and 5 year cumulative incidence rates of 13 and 24% in this almost 900 patient VTE study. Risk factors for VTE recurrence: severe sickle cell disease, lower extremity DVT as the incident event, pneumonia or acute chest syndrome. Again, no surprises there. Cumulative incidence of bleeding, 5% at 6 months and 8% at a year. And the more severe sickle cell disease was associated with bleeding with a significant hazards ratio. These are the 2019 ASH guidelines. They recommend that if you have a first sickle cell disease and an unprovoked VTE, indefinite anticoagulation because of how much of a thrombogenic condition sickle cell disease is. If you have a first surgically or non-surgically provoked VTE, the guidelines don't recommend indefinite anticoagulation, but anticoagulation over 3 to 6 months, like we would in a patient with a provoked VTE. And then recurrent provoked VTE, again, indefinite anticoagulation is preferred over shorter periods. This was kind of good to summarize that SCD is a chronic underlying risk factor for initial and recurrent VTE. Type, strength, and duration of provoking events dictate the duration of anticoagulation. And the decision to remain on anticoagulation should be a shared discussion, of course. Indefinite anticoagulation is not recommended for first provoked VTE, but for a first unprovoked or a recurrent unprovoked, definitely indefinite anticoagulation should be the way to go. And anticoagulation selection, like we would in any other patient, would be based on the patient's comorbidities, renal impairment. In the given example of havedoxaban does not work well if you have higher creatinine clearance. This was a good algorithm about how I treat by Dr. Shett. Essentially, if you have a suspected DVT or VT in a patient with sickle cell disease, you do an ultrasound, a VQ scan, and a CTA depending on presence of pulmonary symptoms. If the ultrasound is negative or low index of suspicion on the VQ scan and the CT angio, you've essentially ruled it out. Your high pretest probability, the ultrasound was negative, then you go ahead and do the next step with the CT angio. If you have found out that there is a VTE, you treat it accordingly with anticoagulant therapy, or you would have excluded it, and then that would be the end of the algorithm. It was a good visual presentation on how to work it up. I think that is all I have. Questions?
Excellent, thank you. Does anybody have any questions or thoughts?
Please.
Certainly a problem. I mean, we obviously see long-term and recurrent VTE. I think it's, to me, an ongoing question as to whether we should be doing long-term or lifelong VTE after first DVT PE versus waiting. And do you need more, what is truly provoked versus non-provoked in sickle cell disease, at least remains an open question to me.
Absolutely. Absolutely. That's so true. And kind of everything there is pointing towards the fact that patients are at a higher risk even at baseline. So when do you switch from waiting for the first VTE to just going full-on prophylaxis like you would a hypercoagulable condition. And the numbers pan out, the higher than what we would see in factor V Leiden carriers, for example. It's 4 times higher in sickle cell disease. So I think at some point the data should mature where we say that this is a hypercoagulable state like all others, where we go ahead and anticoagulate prophylactically.
But there's still a differentiation, right? It doesn't happen to everybody. So there's got to
Right.
be something else that will help us understand who's at higher risk
Right.
before waiting for the first PE.
Right. And so we just, one of the projects we're doing here is to try and see if we can do a NGS panel on patients with sickle cell disease to see if there are any genetic mutations that predict thrombotic risk. So
I think it's a fantastic project. I will look forward to hearing more because I do believe, like everything else, there are other predictors of the specific outcomes that occur, and we just need to figure out what they are.
absolutely.
Hi, this is Susumu Inoue. I'm in Flint, Michigan. Actually, I'm a bit surprised to hear that hydroxyurea is a risk factor for VTE or hypercoagulation. What is the mechanism for this?
I don't know if hydroxyurea itself would be, but I think that may be standing in for selecting patients who are at a more
Severe disease?
severe,
Yes, I see.
sickle
I see.
cell
Okay.
disease. Yeah.
Yeah, that
I
makes sense.
concur.
Thank you.
Yeah, I think it's probably the same. That's my best guess.
Yeah.
Other thoughts? All right, well, thanks for everybody's help and suggestions on the case and attention to the didactic. If you'll look in the chat, we do have that link up for CME and CEU. And otherwise, we'll look forward to seeing everyone in 2 weeks, and thank you again.
Thank you.